Welcome everyone to our global panel in IP 2100. I am a part of a group called Interprofessional.global. It is a group of regional networks from all over the world. And through my collaboration with these great colleagues, we're able to put together these types of panels. And as you see, there are bios of all of our speakers on Canvas. But I'm going to turn it over to Alison Power. She is a colleague from the University of Northampton in the UK, and she actually helped teach this class in the spring of 2024. She worked with us virtually during the semester, and then she actually spent a week here in St. Louis in April. And I'm going to turn it over to Alison. She will be our moderator, and then we will have each of the people presenting. Oh, there's Michael. Good to see you, Michael. Hey, John, Gilbert, can you turn your video on real quick just so we see you? Excellent. So, Alison, take it away.
Thank you so much, Tony. Hi, everybody. I think it was actually on that very stage, wasn't it, Tony, that I had that teaching session with you. It is the same room, isn't it?
Yeah, it is. Yep.
Yeah, some fabulous memories from my time in St. Louis. Anyway, never mind, I'm there today, but obviously only virtually. So it's my absolute pleasure to be moderating this global panel of really esteemed colleagues across the world in relation to interprofessional education. It's my job to try and keep them to time, which historically has been quite challenging because they're all so passionate. It's very difficult to shut them up. So how we're going to do it today, panel members, is that when you've come to time, I'm going to be very nice and I'm going to do a little heart on the screen. Can you all see the little heart flying at the screen, which is saying you've got a minute left, please wrap it up. So that's the way we'll play it today, if that works for everybody. So as Tony said, you've all had access to the bios of our panel, but we're just going to have a quick 5 minutes. We might not even need 5 minutes for everybody to individually just pop in, say hello, and just tell us a bit about your current role. So if I go down my list, if we could start with Luzaan, please.
Good afternoon, everyone. Thank you so much, Alison. I'm Luzaan, Africa, from the University of the Western Cape in Cape Town, South Africa. I'm currently a lecturer. I was recently promoted to senior lecturer, and my role there involves delivering a interprofessional curriculum to undergraduate and postgraduate students. I'm also involved in the Africa Interprofessional Education Network, where I recently ended my term as the secretary, but now I do all the social media. Don't go on the social media yet. I haven't had a chance to update it very recently, but that's my duty at AfriPen. Thank you.
Thank you so much, Luzaan. And next, James, welcome.
Thanks, Alison, and yeah, nice to see everybody sort of on the screen. I'm coming to you from Western Australia. So I'm actually a physiotherapist by background, originally from the UK, as it happens. I trained as a physio in London, but over 20 years ago, I moved out to Western Australia to sort of pursue my career, and I now live in a town called Broome, which is in the far northwest of Western Australia. So it's about 2,000 kilometers from any other city, and we all get to and from work on kangaroos and wrestle crocodiles most evenings. That's the kind of part of the world that we live in. So my role now, like I'm still a physio, but I actually run a department up in Broome for the University of Notre Dame that specializes in rural health. And we, as I'll talk about a bit later on, like one of our specialties is because in rural settings where there are workforce shortages throughout the region, interprofessional practice takes this critical role. And so our department, sort of, we have students come to us from all around Australia, and they do these rural pracs where we do them in this very sort of interprofessional way. because that reflects what's needed in rural practice in Western Australia. So yeah, that's my background, and yeah, it's a real pleasure to be on the panel. So yeah, nice to see you all.
Brilliant. Thanks so much, James. If we could go to John, please.
Well, good morning. I actually am just up the road from all of you there, and it's great to be on the screen again. I'm in Vancouver, Canada, up in the northwest corner of the continent. I have a very, 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 very long association with interprofessional education. When I was appointed to the University of British Columbia in 1966, that'll tell you how old I am. The Dean of Medicine had recently published a paper about learning together to work together, and was the first person to use the word interprofessional. So I figure I've been living and breathing this for at least 60 years. My major interest for the last 40 years has been the policies and policy making that surround health professional education. And that has a big impact both at our regional level and our federal level. And I continue to have that interest. Thank you. And it's very good to be here. Thank you, Alison, all my relations.
Thank you so much, John. And Vikki.
Hi, everybody. Great to join you today. So I am joining you from the northeast of England, which means that I am a Geordie. It's absolutely lovely to meet you all. And ultimately, my role is, well, which role would you like first? Let's think. So I'm a nurse by professional background. I work at a university in the kind of the middle of the country, actually. So I work at a university called Teesside University, and I'm also a trustee and board member of CAPE, which is the UK organisation for IPA, and that's the Centre for the Advancement of Interprofessional Education. Along with Alison, we're both trustee board members of that organisation. That's been around since 1987, so it's a leading organisation across the world for driving advancements in interprofessional education and collaborative practice. Work with all of these wonderful colleagues that you can see on the screen in lots of different international groups. And I guess collectively, we all have the shared goal of driving health professions to be able to work together more effectively, to learn together, and to drive quality and safety. So incredibly passionate about that work. My doctoral work explored interprofessional learning culture within the environment of critical care. So that's, I think, what we're all passionate about. We're about passionate in terms of driving education, but making sure that translates into practice. That's me. Thank you, Alison.
Thanks, Vikki. Jan-Jaap, over to you.
Yes, well, here it's in the afternoon at the end of the normal Dutch workday. So thank you very much for the invitation. My name is Jan-Jaap Reinders. I'm a work and organizational psychologist, and my PhD project some years ago focused on interprofessional education and collaboration. I'm still focusing on this. I'm also a board member of Dutch-speaking network, IPINN, and actively involved in Interprofessional.global. My focus as a work and organizational psychologist is specifically in identification processes. So how social processes result in a sense of belonging, commitment, and beliefs. And of course, also related to interprofessional collaboration. I have many I have the affiliation with the Hans University of Applied Sciences, but also the University of Groningen. And I work at very proudly, the largest academic hospital in the Netherlands in the north, and that's the University Medical Center of Groningen, with a bit more about 13,000 staff members. And I do a lot of education, interprofessional education, and also research in education, primary care, secondary care, and other specialized fields and settings.
Many thanks, Jan-Jaap. And I think we have got Mike here, haven't we? So Mike, would you like to introduce yourself?
Hello. Hi, everyone. Can you hear me? Good? Hi. Hi, everyone. My name is Michael C. You can call me Mike. I'm an occupational therapist by profession, and I'm so happy and glad to be invited once again in this module at the St. Louis University. My involvement with interprofessional education started during my master's studies in the Philippines, where I studied health professions education. And IPE became my thesis project because as an occupational therapist, in the field of our clinical practice, we couldn't imagine working alone and with patients. We need to always have our physiotherapy colleagues, speech therapists, nurses, doctors working with us to ensure that the patient outcomes that we want to achieve is achieved. So it's always, my profession has always provided us with this collective perspective when it comes to working. So that's why I got interested in interprofessional education, which continued when I studied for my doctorate in Tokyo Metropolitan University in Japan, where I studied about substance use and addiction and rehabilitation in the Philippines. What else? I also am able to teach right now at the Zurich University of Applied Sciences, where I am based. I teach at the bachelor's program in interprofessional education, where we have students coming from different programs, such as nursing, midwifery, physiotherapy, occupational therapy, public health, and our new program is on bioinformatics. Aside from that, I also work closely with the people around here who are in this panel in writing journal articles. I'm also working as editor in the Journal of Interprofessional Care, among others. And lastly, I'd like to include my current role as the representative for the promotion of IPE in the Asia Pacific region, which is the Asia Pacific Interprofessional Education and Collaboration Network. So that's from me, Alison.
Brilliant. Thanks so much, Mike. Sorry, I didn't say anything about me. Just to say, obviously, as Vikki said, that I'm on the board of CAPE. I'm a midwife by background, and I am a faculty lead for IPE at Northampton, and also the Schwartz Round lead as well there. And yeah, work a lot with everybody on this panel. So it's fantastic to be working with them again today. So for the next part of the global panel, we're going to go to each panel member in turn, and I'm going to be asking them a question about the health and social care system in their country specifically. And that's going to be really helpful to you, as I know a project, a part of this module is looking at a healthcare system in a particular country across the world. So you've really looked out if your country is one of the panel members today. So I'm going to go in the same order as I went before, and each panelist will have 8 minutes. And while the panelist is talking, we'll all turn our cameras off so that you have a really good view of that individual. So Luzaan, you're up first. And the question is, could you please describe the health and social care system in your country, highlighting its successes and challenges? So over to you, Luzaan.
Thank you so much, Alison. I think before I start, I need to point out that I am a physiotherapist by trade. People always joke that I'm not a physiotherapist, and then I went and forgot that I'm actually one. So I just need to mention I am a qualified physiotherapist. To share a bit about the South African health system, I think we first need to understand a picture of the country itself. So South Africa is home to just over 65 million people, and it's a population that is rich in cultural, linguistic, and racial diversity. Roughly 80% of the population identifies as Black African. About 9% identifies as colored, which is a race classification that I fall under. And it is politically acceptable in South Africa to be identified as such. 8% white and 3% Indian or Asian. And this diversity really shapes not only our unique identity as South Africans, but also the patterns of inequality that was born out of our painful history of apartheid. This regime marginalized 90% of the population. So if for those of you that are unfamiliar, apartheid was about the marginalization of people of color. And so if you listen to the racial breakdown, 90% of the population was marginalized about it. And this pattern is now embedded in what our health system looks like. So South Africa operates on a dual health system that is a public sector and a private sector. So the public sector serves about 75 to 80% of the entire population. So of that 65 million that I spoke about, it services or serves 80% of them. And this includes the most vulnerable and socioeconomically disadvantaged communities. The care in the sector is either free or it is heavily subsidized by the state or by our government. The private sector, on the other hand, serves about 20% of the population, and largely to those who can afford out-of-pocket payments or those who have medical aid. And medical aid is our version of private health insurance. Medical aid schemes also vary quite widely. The more you are able to pay, the more extensive the benefits. In most cases, employees subsidize a portion of the monthly premium, but many South Africans, especially workers, casual workers, and those in informal employment cannot access these benefits and therefore remain reliant on the public sector. So there's one additional pathway to private care, and that is injury on duty cases. So if you are injured at work, for example, falling off a ladder at work, the employer is legally responsible for covering that private healthcare cost. But even here, the funds allocated per case are capped, and that can be depleted before the end of the treatment or the intervention, which pushes those people back into the public health services when that money runs out. And so just to come back to our public sector, that is structured across 3 levels. We have a primary healthcare level, secondary care, and tertiary care, and we also have specialized centers and rehabilitation facilities. So primary healthcare is really the backbone of the South African healthcare system. Since 1994, with the abolishment of apartheid, primary healthcare was made free at the point of access to all South Africans. So people can walk into our community clinics, our day hospitals, our community health centers without a referral. The nurses conduct triage, they issue referrals and dispense medication up to a certain schedule without patients ever seeing a doctor. Then there are cases where the patients are obviously then referred to the doctor. Then the secondary level hospitals, which are our district and regional hospitals, they manage the more complex conditions, and those are usually from referrals from the primary healthcare or emergency units. Then we have the tertiary level centers, and these centers really, or hospitals, they manage specialized care cases, major surgeries, and advanced diagnostics. And so I thought about how to do it slightly different this year. And last week, just to tell you a bit of an experience, to share an experience with you, I want to share a real life story of myself and that of a colleague. So last week, I was admitted into a private hospital for gallstones, the most painful thing I've ever experienced. But then earlier this year, a colleague of mine who is not on medical aid because she's on contract at the university, so she's not subsidized for medical aid, she was admitted for exactly the same condition into a public hospital. So within a 15-minute drive, I could choose between 4 or 5 private hospitals, while my colleague only had access to 1 public hospital in the same radius. When I arrived at my private facility, the waiting room had about 3 people in it. I was in too much pain to count. But within minutes, I was at the reception, and shortly after that, I was seen by the triage nurse. And within 10 minutes, I was called for further observations into a small cubicle. I wasn't on the highest priority list at all. I had orange on my tag. I don't even know what the colors mean, but orange is not on the highest level. But I moved through the system quite quickly. The physician on call then saw me, the blood, an ultrasound, and over 2 hours, the physician on call came and apologized for the delay in the feedback that I was given. And then if we shift to my colleague, she was sitting in a waiting room, or she came into the waiting room and there was absolutely no place for her to sit. That's how full it was. And it took hours before she was even registered at the intake desk. By the time, if you had to consider the time difference, by the time I was comfortably admitted into my ward with 2 beds, I could actually choose which bed, and I chose the one at the window. She had not yet been seen by a doctor. And when she was eventually admitted, the hospital was so full that she had to spend several days in the corridors of the hospital on a gurney, a hospital bed. where men and women were all lined up in those corridors, all waiting for treatment. There were no curtains for privacy. She had to carry her belongings with her when she went to the bathroom because she didn't have a bedside locker like I had. I shared my room with no one, and I had my own bathroom. So by the time she received her first consultation with the physician, I already had my complete treatment plan. Both of us, however, I think to mention the positives, received compassion from nurses who were doing their absolute best in impossible situations in her case, but the systems that we were in were completely different. And this brings me to the National Health Insurance, or the NHI, which is South Africa's proposed reform plan. The NHI seeks to create a single unified health fund that pools the resources that is currently split between public and private sectors. Thank you, Alison. This NHI is set up in a way where you can access care based on where you live and work, not on the size of your wallet. And so implementation of this NHI will obviously be very complex, and there's massive debates in the country around this. But the vision behind the NHI is rooted in a deep desire for equity to ensure that the quality of care that I received last week is not a privilege for few, but a right for all South Africans. Thank you, Alison.
Thank you so much, Luzaan. That was great. And that was quite a gentle reminder, wasn't it? A little kiss rather than shouting at you. So thank you so much. And just to tell the audience, if you have any questions, if you can just make a note of them, and then we will answer all of the questions at the end of the panel. So thank you, Luzaan. And we will now go to James, please.
Yeah, thanks, Alison. So just a reminder to everyone, I'm talking about the Australian healthcare system. So I'll start by just giving you a little bit of context. So Australia, as I'm sure most of you will know, is this huge country. The landmass of Australia is about the same as the continental United States, but one of the big differences is our population is much, much smaller. So our population is about 26 million people, compared to what in the US is over 330 million, so a much smaller population. The other thing to note is the Australian population is centered around about 6 major cities. So you've got 90% of Australians living within these cities, and then this vast outback where very few people live. The geography of Australia is very varied, but in fact similar to the US in that regard. So you've got sort of temperate climates, you've got cold climates, and then you've got tropical climates up in the north. The other, I suppose, contextual thing that I think is important when thinking about healthcare in Australia is thinking about the history. So the Indigenous population of Australia is the longest continuing culture on the planet, stretching back tens of thousands of years, and that's a very rich and proud culture. And then the British came to Australia in the late 18th century and colonized it, and Australia is still reckoning with the blending of Western cultures and Indigenous cultures to this day, in a similar way that I think is happening in a lot of other Western cultures, including the US, but it's very, very apparent in Australia at the moment. So this kind of concept of reconciliation is a really important thing in Australia at the moment. And we see that a lot in the way that healthcare is delivered. So if we talk about how Australian healthcare system is structured, Australia has a mixed public and private system. So from the public perspective, Medicare is Australia's sort of public universal health insurance system, and it's actually very effective. So healthcare is free at the point of contact for all Australians. So if you don't have any private health insurance, if you don't have the means, you will get healthcare in Australia without having to pay. So that's especially relevant for visits to the emergency department, but it can also apply for surgery and specialist care as well. Likewise, primary care is funded publicly. The other thing that is publicly funded or heavily subsidized is the pharmaceuticals benefit scheme. So if you are prescribed medications, then you will receive that heavily subsidized by the state. So that's good news if you don't have the means to pay for your healthcare. However, there's a private system as well that runs in parallel to the public health system, and this works really effectively. And essentially, what's quite elegant about this system is in Australia, the government recognises that if Australians are paying for health insurance either personally or through their employer, that removes a burden from the state. So there's a lot of tax incentives to Australians to get private health insurance. So there's a lot of Australians do have private health insurance. And essentially what that does is it doesn't make a lot of difference to visits to the emergency department, doesn't make much difference to primary care. Where it does make a lot of difference is when you're accessing specialist care or elective procedures. Your insurance is going to deliver a quicker visit, a quicker procedure, and more choice and more trimmings around the nature of that care that you're getting. So there's quite a nice complementary public-private system, and that works very well. I'd like to draw your attention to a couple of the challenges that I think are unique or mostly unique to the Australian context that I think is worth noting as we're here talking about different global health systems. So firstly, the first challenge I want to bring to your attention is the challenge of delivering healthcare in rural settings. I said in my introduction that I work in a rural setting, and so a large, significant proportion of Australia's population lives in rural settings, and many thousands of kilometres from those 6 major cities that I made reference to. So having staff in those rural communities is very difficult. And delivering specialist healthcare in those communities is very difficult. So it's quite challenging to either bring healthcare services to those rural communities or transport those patients or clients to those specialist centres. So we have good general care in rural communities, but the specialist centres, you just cannot distribute them around the country the size of Australia. And so that's quite challenging. And the other problem that goes with that is politically, investing in rural healthcare is not helpful for political parties. And so rural Australians receive about $2,000 less funding per person per year than metropolitan Australians. So that's a challenge that we're still working to overcome. That's the first thing. So rural healthcare, I think, is a real challenge in Australia, and that's quite. I feel it's quite unique, certainly in the extent that is in Australia. I think the second thing that's worth mentioning is this idea of culturally appropriate healthcare. So in Australia, and particularly in rural communities, so in the community where I live up in the northwest of Australia, which is very remote, 40% of the population in the region where I live is Indigenous, and they have special cultural requirements. And so for them to be receiving Western models of healthcare is incongruent with many of their cultural practices. So delivering culturally appropriate care to Aboriginal Australians is something that's really challenging, and we're working on that. And I think one of the ways to combat that problem is to be training more Aboriginal healthcare workers. But to do that, we need educational pathways that are going to be able to bring Aboriginal people from Aboriginal communities to learn those health careers so that they can service their own communities. This is a big challenge. I think it's present in other countries where there are Indigenous populations, and it's something we're working very hard at. So that's something I think you should bear in mind when thinking about the Australian healthcare system. Thanks, Alison. I think that's about all I had to say, and hopefully on time.
That was literally on time to the second, James. I'm very impressed. Thank you very much for that. There you go. So next to John, who's going to tell us all about the Canadian systems. Thank you, John.
Thank you, Alison. Well, Canada's health and social care system is publicly funded, it's decentralized, and it's designed to provide universal access for residents. It's celebrated for equitable coverage and very strong health outcomes. Canada considers health and social care to be a fundamental right and not a privilege. Just a few observations then about the structure of the system. Healthcare in Canada is funded primarily through taxes and administered by 10 provinces and 3 territories, from the Atlantic Ocean to the Pacific Ocean to the Arctic Ocean. And each of those has its own insurance plan, but it has to adhere to national standards under the Canada Health Act. Medicare covers all eligible citizens and permanent residents for medically necessary hospital and physician services at no charge. And there are additional services varying by region, again, at no charge because there are regional needs that need to be covered by the healthcare system. Specific population groups like seniors and Indigenous peoples may receive additional coverage, often for drugs or long-term care. By drugs, I mean pharmaceuticals. Social care, including housing, poverty reduction, mental health services, they all operate through intergovernmental collaboration. That is, means the federal government and the provinces and territories. And depending on the needs of the nation, we have specially targeted programs around specific issues, for example, with COVID. Okay, 6 successes. Universal coverage in Canada ensures that care is based on need, not ability to pay, which then supports social equality and inclusion. Administrative costs are far lower than in mixed or private systems because we have efficiency and system-wide cost control. Governments are able to bargain with pharmaceutical companies on pricing, for example. And outcomes like, for example, life expectancy and infant mortality are competitive internationally. We have very good infant mortality and maternal mortality rates. And the infrastructure of the public health system is very robust. It worked very well during the COVID pandemic. 99% of Canadians report having a regular healthcare provider or place of care, but I'll say a word about this in a moment. Reforms and substantial investments, close to Canadian $200 billion over the past 10 years, have targeted and continue to target priorities like access to care, workforce capacity. Do we have enough of X, Y, and Z professionals? Modernization through robotics and AI. And then, of course, the big burden that every country has, which is primary health care. And we are really working hard on reforming primary health care in this country. As I said, we do enjoy strong fiscal savings because of our negotiating power and universal purchasing for health technology. And that's proven to be a very interesting policy problem over the past 3 years as AI has really skyrocketed and robotics gets more and more robust. 7 challenges. Well, we have long waiting times for non-urgent procedures and some specialist care. They remain a widely acknowledged issue, but it's not peculiar to Canada. Long waiting times, it doesn't matter whether you have a private system or a public system, there's always going to be some glitch in the system, which leads to a long wait time. Access to primary care is inconsistent. As I said, 99% of our population will say they have coverage, but in rural and remote areas, sometimes it's very difficult to make contact with your primary healthcare provider because of the distances that need to be covered in order to meet that primary health provider. And we are also working on that issue. Indigenous populations continue. We have the First Nations, Métis, and Inuit peoples in our country. They continue to face poorer health outcomes, inequitable access, the effects of systemic racism and exclusion in care settings, which, as we have heard, is a long-term effect of British colonialization. And we're working on that. We have Truth and Reconciliation Commission that produced over 150 recommendations, which we're now working our way through. Fragmented coordination between health and social services and social care leads to gaps in care for vulnerable populations and those with complex needs like COPD, diabetes, etc. But again, fragmented coordination between health and social care is not peculiar to Canada, as my colleagues in the United Kingdom will agree. Canada has staff shortages in certain occupations. Every country does. It has concerns about compensations for providers. Every country does. And caregiver burnout affects service delivery and sustainability. Again, every country has this issue, and it was absolutely acute, of course, during the COVID pandemic. There are persistent inequities in social determinants of health: housing, poverty, food insecurity, mental health. They remain a burden on both healthcare system and the social care system. And of course, they have a huge impact on population well-being. And we don't spend enough time in our educational programs talking about social determinants. Climate change, we all know about. Aging populations, we all know about. They're not peculiar to Canada, and they are in fact placing new and very complex pressures on the system's resources and capacity, as are robotics and AI, and we could have a very long conversation about that. So what are some takeaways? Well, Canada's ability to get timely care varies widely by province and even within provinces, but it's not extreme. There are other places which have even worse problems about timely care. We have noticed that provinces who have a higher investment in primary care, urban-rural provider mix, and integrated models, and there's a lot of work around integrated models, generally show better access and shorter wait times. Persistent gaps remain in rural and remote areas, and that requires health system innovation and workforce expansion. So our system continues to evolve. Reform attempts are centered on expanded access, support for health workforce, Indigenous governance, digital modernization. But as in every healthcare system, systemic and social challenges persist and will persist. And it's not surprising, given the complexity of the system which exists within the Canadian Federal, Provincial, Territorial Federation. Thank you for your attention. All my relations. Thank you, Alison.
Thank you so much, John. And moving on to Vikki now to talk about something I should be familiar with as well, but healthcare in the UK. Over to you, Vikki.
Thank you, Alison. So I think a good place to start is to think about the structure of care in the United Kingdom. And whilst we've all heard, I'm sure, of the National Health Service, the care that's actually provided or is accessible in the United Kingdom is a little bit more complex than that. So the NHS was actually launched in 1948. We follow the Beveridge model of care, and that again is free at the point of contact. And the idea is that it's universal health coverage. So this is free to everybody at the actual point of contact with a service. So the NHS is the largest provider of healthcare that we have in the United Kingdom, but we also have some other elements to consider. So if we think about the NHS, we have primary care, which would be general practitioners, GPs, for example. We also have secondary care, which would be delivered more likely in hospitals. So these are often urgent or planned types of provision. We also have tertiary care, which is specialist level care. And then we have other services such as mental health provision. We have the private sector as well. So we do have private care in the United Kingdom. And we also have social care. Now that's provided by our local authorities rather than being provided by the Department for Health and Social Care. And we additionally rely often quite heavily on voluntary and charitable services as well. So all of these things are needed really to support the NHS and to make sure that the care is available for people when they require it. One of the things that took place in the United Kingdom a couple of years back was in England, they actually decided to segregate regions across England. We have 42 integrated care systems. Where I live in the northeast of England, we have the largest integrated care system, and they have just been asked very recently to reduce their budget by 50%. So that starts to give you a little inkling into some of the challenges that I'll be talking about as I continue telling you about our systems. So, thinking about the NHS, it's a very large organisation. It's the fifth biggest employer in the world. It's sandwiched beautifully between Walmart and Amazon. So, it's a very, very large organisation. It employs 1.7 million people and it spends almost £200 billion a year on care, on services. And what that actually means is everyone who's within England, those of working age, or those who are within the employment population, 1 in 17 people work for the NHS. It starts to give a little bit of insight into how large the NHS provision is. And within that, we have, for example, every year, 2 million people will access accident and emergency, the emergency department. So it's a very large, very complicated, and very heavily utilised service for the people that live in the United Kingdom. So in terms of context, something to point out as well in the way that the country works in terms of governance and policy. So the United Kingdom is made up of 4 countries, and overall we have about 68 million. This is predicted to get to about 70 by 26, 27. So we're looking at 68 million people. 58 of those are inside of England. We have about 5 in Scotland, 3 million in Wales, and almost 2 in Northern Ireland. So we have an awful lot of people inside of what I would suggest if we think about Australia and how diverse and rural Australia is, that's a lot of people packed into quite a small space. So it's really interesting and important to acknowledge that these devolved nations deliver their care in different ways. So if you cross the border into Scotland, for example, you won't pay for a prescription. In England, it's now gone up to £9.90. So that's approximately $13 by conversion. So there are quite stark differences in the way that care is delivered in the different countries, and these are governed by those national organisations and those national governing bodies. So I think it's important to think about context. Now, in terms of population size, this is also something that I'd like to raise your awareness with today. So we ultimately have approximately 70 million people by 2026 who will be inside of the United Kingdom. And what this means for us is we have a growing population at the moment. As John's alluded to, this is not unique to the United Kingdom. And ultimately, about a fifth of our United Kingdom population is over the age of 65. And as a general rule, across the United Kingdom, we actually have less people dying than we do being born. So we have this swell across the population where the population continues to grow. And as people continue to grow and we continue to provide care, people are developing more comorbidities, more illnesses as they're living longer, because the life expectation in the United Kingdom has gone up by about 13 years since the NHS was launched in 1948. So this is wonderful, but it also means it's placing increasing demand on the services that we have. So if we focus, I think, on the strengths of the NHS and the system that we actually have across the United Kingdom, there are some really, really big success stories, such as stroke and cardiovascular disease halving since the NHS was actually launched. Our systems are based on the principles of equity, on accessibility, on social justice, and it is free to most at the point of contact. In terms of the way that it's funded, about 1% comes from chargeable costs. So, for example, if I go to the dentist, I actually have to pay a fee. If I get a prescription, I have to pay $13 per item that I get on prescription. So about 1% of the NHS is funded by this. The majority of it is through taxation for the employed. So employers and employees pay taxation, and that is how it's actually funded as a public organisation. And so All of these things are wonderful. It means that because of the way it's taxed at the point of contact, it is generally free. It meets the needs of millions of people. And we have lots of plans in place, and these plans recognise how integral the workforce are. We recognise how important it is to have integrated care, which is why we now have integrated care systems led by integrated care boards. So there are lots of drivers to make really significant improvements. So there's a lot to celebrate in the NHS. If we shift to the challenges that we face a lot of challenges that aren't unique to the United Kingdom. We have the growing population, the growing demands on the service. We do have shortages. And I think just to raise your attention on some of the most recent challenges that we're facing, we've just had another strike. So resident doctors, medical doctors, junior doctors have walked out again because of disputes over salary and pay. So we have a lot of issues at the moment in terms of retention and a lot very unsettled workforce. We're going through a cost of living crisis at the moment. Prices have gone up astronomically and continue to do so. We're also having a university crisis across the United Kingdom. Tens of thousands of people are losing their jobs at the moment, and this is starting to hit the NHS now as well. So newly qualified graduates don't have jobs to go to at the moment, but we have shortages and not really ways of actually funding them. So I think these are some of the big situations that we're managing in the United Kingdom. And I guess a takeaway and a close for me is that we remain really proud of the NHS. The NHS Constitution states that the NHS belongs to the people, and we're really proud of that institution. We fight really hard all of the time to retain that ethos of equity and access, and interprofessional education and collaboration is more important now than it's ever been before to drive forward and to make sure that we offer universal healthcare coverage for people who need it when they need it. Thanks, Alison.
Thanks, Vikki. That was great. And now Jan-Jaap, who's going to talk to us about the Netherlands. Over to you, Jan-Jaap.
Yes, thank you very much, Alison. Well, yes, I am from the Netherlands, and Netherlands is a relatively small country, but it's part of one of the four countries of the constitutional monarchy of the Kingdom of the Dutch Kingdom. And it's about 18 million people in this small country. It is the third country with creating a little bit of context. It's about the third country with the highest population density in the world. So 18 million, very small. We have 12 provinces. I'm from the north, and a lot of people do not call us the Netherlands. They call us Holland. But actually, Holland is a province. It's one of the most dominant provinces of the Netherlands. So Netherlands is plural because we used to be a collection of very, very small countries. So with regard to the Netherlands, just a bit of context, we also have two languages, Dutch and Frisian, but Frisian is a very small language group. A large part of us is also beneath the sea level. And just to make a point of reference, about 25 to 26% of the Netherlands is below sea level, and this costs us 1.5 or about 1.5-2 billion euros a year, which sounds quite a lot. But if you look at the costs in Dutch healthcare, which is actually rising, is now an estimate about more than 100 billion a year, and it is increasing. So the increase with regard to past year is in total an increase of 8.1%, which also, of course, shows how challenging this becomes, because the population, the demography of the Netherlands, of the Dutch population, is kind of an upside down pyramid almost. Well, not really. It's more like a different shape. We have a lot of elderly people. We have an increasing amount of people with multi-morbidity, with comorbidity, a lot of elderly people. but the population with regard to people employed is decreasing. So the amount of people that can really take care of the elderly and of the sick are decreasing a lot proportionally. So in the Netherlands, about 1.7 million people are working in healthcare, and the numbers are rising, especially in nursing. And this is about 17% of all the employed persons within the Netherlands itself. So there's about a bit of context or demographics, a bit of context about the Netherlands. So also, what's important of how it's financed, we have a dual system with regard to our healthcare system. Part of it is government funded. This is based on taxes. It's funded by taxes. But we also have a mandatory insurance with premiums that we have to pay. So it's a dual system. And sometimes, for instance, for dentistry, if you're older than 18 years old, then you also have to pay an additional fee. So the costs are rising, and everybody in the Netherlands is noticing this. However, the good thing is that still the healthcare in the Netherlands is quite accessible because we have mandatory insurance. We see also a positive change in policy for the past years, focusing on more prevention and more integrated care. And we see this also with the rise of the increasing number of funding for projects, for development, and for research, but also education, to focus more on interprofessional collaboration. However, these grant calls are extremely competitive, so it's very difficult still to get that money that you need to move things forward. However, it is progressing, and that's positive. There's a lot of innovation with regard to healthcare, also a focus because we have more and more people who require care. We have an increasing cost. So the policy in the Netherlands is to support elderly to be as self-supporting as possible, as long as possible. So stay at home as long as possible. That is the focus, and therefore we try to introduce use more e-health, more personalized medicine. There's more and more data-driven tools also to monitor and change how we deal with healthcare. And we have a capacity planning specifically based on research on the numbers of students per health profession that should be trained. So that is good. Also more focus on value-based care and cost effectiveness and high quality of care. And the regulated insurance system keeps the spending relatively controlled. But as I have mentioned before, this is quite relatively because still the numbers are increasing very rapidly. Long-term care, for instance, has increased with 7.2%, and the basic package with 5.9% per year. So that is increasingly problematic. Talking about challenges, we do have staff shortages in healthcare. Mental care is at the biggest problem. We also have a postnatal care crisis, where it becomes more and more difficult to support parents, new parents, especially with low pay and high demands. We see that the interest for the workforce and midwifery, for instance, has become very problematic in the Netherlands. It has been also a recent news item, so this is very up to date. We have an aging population, as I told you before, which also means that we have more multimorbidity and more people that need care. The number of waiting times also for surgery in the Netherlands is is becoming more and more problematic. A lot of care is delayed, which also means that a lot of people have more difficulties with their health because of this, and maybe even more dramatic outcomes because of this. The health inequalities are also at a more regional level. We see it especially in the south of the Netherlands and the far northeast of the Netherlands, that the poverty is increasing rapidly. And this also means that you live in those areas, people live less longer, a couple of years less longer than other people in the Netherlands. We also have other challenges like fragmented systems, limited exchangeability of certain systems that we use, and information exchange. And of course, the latter is very important because this is also important for the process to unify and standardize process for interprofessional collaboration. The good thing is, let me end this story positively, is that interprofessional education and interprofessional collaboration becomes more and more prominent, both in healthcare and both in hospitals. There are more policies, and there's a lot of progress going on, but we do not have a lot of time given the challenges we face. So this is about a snapshot, a snapshot of the current situation in the Netherlands.
Perfect. Thank you so much, Jan-Jaap. And finally, we go to Mike. So Mike, if you could please focus on healthcare in the Philippines, and then we should have about 5 minutes at the end for a brief discussion. So thank you, Mike. Over to you.
Good. I prepared a Word document so that I'm on time. Thank you, Alison. So the Philippines is an archipelago with more than 7,000 islands with almost 117 million people. Just to give you that an idea how big that is. For example, Manila has a population of 15 million, which is double the population of the whole of Switzerland. So that's how big the country is and how populated it is. It is a low and middle income country with a disparate distribution of socioeconomic shares among the population. So you will see a lot of people who have different kinds of socioeconomic statuses. Most of them, 70%, are in poverty, and 30% are sharing the middle and the upper classes. English is also one of our official languages, and we speak English well, I think. And we also include some Spanish words, hundreds of them in our own language, not because we are good in languages, but because of the consequences of colonization. The Philippine healthcare system today is a landscape of both progress and persistent challenges. On one hand, we can take pride in important strengths. So I'm going to outline them for you. We have a universal healthcare coverage law through the Philippine Health Insurance, although it is not yet implemented after so many years, but it is coming. We are hoping that it will come soon. We also have a dedicated, young and skilled, highly skilled health workers. And in the Philippines, going into healthcare is highly esteemed by the community and families. So usually the educational programs in health and medicine and nursing in the Philippines is very sought after or with high standards, and it becomes a pride to the community when you are part of the healthcare industry. We also have a lot of dedicated and highly skilled health scientists. Another strength is the strong community-based programs that bring essential services closer to families. Healthcare starts at the barangays. We call barangays our villages or communities. So health can be accessed through the smallest unit of our community called the barangay. Our growing private sector is also a strength because we are seeing a lot of expansion of private primary care initiatives also reflecting more access to healthcare. Yet we must also face the realities that continue to hold us back, and I will also outline them here. Many Filipino families still struggle with high out-of-pocket costs, which is a big problem for many of those who get sick or those who are disabled. The quality care remains uneven, especially between urban centers and remote communities. So when you live in an archipelago, it is important to consider transportation of medical professionals going from one island to another through boats. So we have boat ambulances, and because of the economic status of the country, we don't have a lot of helicopters who would become ambulance for people who are sick or need emergencies. So boats and also long rides from point A to B must be considered. Our public hospitals and even private hospitals are often overcrowded because of the space and also the amount of health, because of the shortage of health workers that we also are experiencing. And speaking of shortages, we also experience shortage of health workers, not because we're not producing enough. We are actually producing a lot of graduates from healthcare programs, but the shortage is driven by the global migration, where our healthcare workers are exported to, and I would like to emphasize the word exported, because we see this as a human exportation to host countries. And host countries can mean the US, the UK, Ireland, the Middle East, Australia, New Zealand, basically where there are more opportunities, better pay, better conditions. But in some cases, and this is my critical view on the global migration of nurses and healthcare professionals from the Philippines to the host countries, in some cases, this is at the expense of the consequences of austerity measures in these host countries. I think it's good for the Filipino workers going abroad because individually they will get better pay and better conditions. But usually this process or phenomenon is a solution to the austerity measures of the host countries because they're trying to do budget cuts. So usually there is a chance that most of these Filipino workers might be the solution for austerity measures abroad. And altogether, these realities strain the already fragmented healthcare system that we have. And I think as I end, I would like to share with you that the country is doing is dealing with a lot of issues right now, and healthcare is one of them. But it is important that as healthcare professionals, we acknowledge the strengths and weaknesses of our healthcare system, because our system is unique and each healthcare system is unique. And I think when we identify our strengths and weaknesses, we can always find sustainable and context-based solutions to better the healthcare system. Thank you.
Mike, I didn't get to send you a love heart, so I'll send one anyway. Thank you so much. That was really timely. Brilliant. So if all our panel members would like to put their cameras back on, I'm conscious of time, as we say. And what we're going to do now is we're going to have a quick fire round. And each of our panel members, I'm going to give you 30 seconds to give me your pearl of wisdom or your takeaway in relation to IPE, and I'll go in the same order so you know when you're going to be coming. So Luzaan, your pearl of wisdom, please.
Yes, so I think my pearl of wisdom that I would like to share is that we have an African philosophy called Ubuntu, which means I am because you are. And so that African wisdom teaches us that a person is a person through other people. And so in global health, it reminds us that systems don't succeed because they are perfect. We succeed because we are connected. And so in panels like this, we really learn about each other and each other's health system so that we can go back and integrate it in some way. And so what we build at home can heal far beyond our own shores. Thank you.
Beautiful. Thank you so much. James, beat that.
Thanks, Alison. The pearl of wisdom I sort of wanted to try and leave with you is I spoke a bit about culturally safe healthcare in the context of Aboriginal Australians, and you heard a bit more about that, particularly from John and also from Mike. But I just want to remind you all that whilst it's really obvious to consider culturally safe healthcare in the terms of, reconciliation and Indigenous populations and colonialisation, remember that every culture has a culture. And so wherever you're working, be that in an inner city setting or in a remote community, wherever you are, that idea of culturally safe practice is contextualized to the culture that you're in. And that could be the culture that you're from, where you're practicing. It could be a culture that you're not familiar with. So take the opportunity to understand the culture with which you're working and be a part of that culture and support that culture, whether that's Indigenous, non-Indigenous, whatever the color of the skin is. I think it's a unified approach to healthcare. So thank you.
Fabulous. Thank you so much, James. John.
You've heard cultural expressions from a number of different areas of the globe. Think about it. Thank you.
Oh, he's good. He's good. I think you're running in the lead, John. Thank you so much. That's fabulous. Vikki.
Oh, mine's going to be longer than John's. You know how my brain works. So I actually think that what we really need to focus on is the why. And the reason we do this is to provide really high quality care that is safe and we can all collaborate together for the good of others. But I think the space that we tend to be moving towards now is how. So I think in the United Kingdom, we recognise that we need to give holistic person-centred care. That person-centred care is so we can meet complex needs and so that we can do that together and prioritise what's important in the moment. And we need to have integrated systems that enable us to work across boundaries. So we need to design with people, for people, and all of us who are on the panel today are probably the world's biggest advocates for interprofessional education and collaborative practice. So join us, I dare you, join us if you will, in this mission to collaborate and bring the world together.
There you go, call to action there from Vikki. Thank you, Vikki. Jan-Jaap.
Well, it's hard to top this. I think jointly we can solve a paradox. With interprofessional education and with collaborative practice, we can solve a paradox. And this paradox is between diversity and unity. We need unity in diversity, which means that we can leverage diversity. As we perceive each other as part of the toolbox, there is no simple challenge. This is complex challenge. These are many complex challenges. It is incredibly important that we understand that we are codependent, because true knowledge is knowing what you know and don't know. You have to learn the extent of your ignorance, but that's Confucius. That's not me. That's Chinese wisdom. So I would like to say, when diversity defines unity, unity creates synergy.
Whoa, that's deep. I'm going to write that down and reflect on that. That's a good one, Jan-Jaap. Thank you so much. And Mike, no pressure. Let's end on a high. Over to you.
I'm just gonna continue the conversation. And I just recently, I think two days ago, I was invited to speak in a conference in Bangkok, talking about interprofessional practice and technologies and AI. And in my speech, I titled my presentation as Interprofessional Practice, the Human Competency AI Can't Learn. So John and I had a short conversation about that, but I'm I just want to share to the young students today that yes, AI and technologies is inevitable. They are there. We're going to use them. They're very helpful to make our healthcare system work effectively and cost effectively as well. But let us not forget that we are dealing with human beings, people. So we need to provide, we need to put out our humanness in the care that we give, because we're dealing with people, not statistics, not numbers, people. So don't forget that.
Fabulous. Thank you so much, Mike. And from me, IPE rocks. So if you come and join us, you too can be a rock star. Back to Tony in the studio.
Thank you all very, very much. Let's have a round of applause for our great colleagues. Yeah, I think, you know, the ability to learn from people that are actually experiencing it and not just from people that are doing the best they can. We really, really appreciate it. I do want you to hang on the screen for a second because we're going to take a family picture as class ends. Megan, do you have a couple of announcements real quick?
So on the final, so Dr. Brackback talked to you guys about the final that's coming up in 2 weeks, right? 50 questions.